Thank you, chairpersons. Thank you, Chetan, for giving this opportunity to moderate this session. Of course, molecular diagnosis is one of the fast upcoming technology, as the initial introduction was given. They have revolutionized the diagnosis of infectious diseases because there is a faster result, the better sensitivity and specificity compared to our classical or conventional methods. Initially came as single test, a single PCR. Now they have come with the multiplex, wherein in one go you can look at many of the organisms. You can do what is called as a syndromic diagnosis. Not much of technical expertise is needed, but the cost is a limiting factor as of now. As we keep doing, probably the cost may come down. So today's panel discussion, we are trying to look at what does it mean, because we say PCR. What is PCR? Nobody knows. So what is PCR? How it is different from the traditional methods, and what are the samples that you can send, what are the samples to be taken, and how do you interpret that? And especially when you get 2 or 3 organisms in the same thing. So what we are trying to do is evidence-based guidelines, evidence-based answers. Rationally, we are trying to give it. When you come to the diagnosis of infectious disease, we have several methods. We culture the organism, we do the stain, we look at the antigens, we look at the polysaccharide on the capsule, so many methods. But one thing is, the unique heart of every organism is a DNA or a RNA. That is more specific. You take a piece of that, amplify it, then you try to study that particular part. So identification of the nucleic acid, it is unique. It is like what you call Jatakam for a person. So it is unique for that organism. And the thing is so successfully, you have seen being implemented in the diagnosis of tuberculosis. Now the future is depending on these things, because we are able to identify those organisms where hitherto we were not able to identify. For example, mycoplasma. For example, some of the viruses. And the time taken, you can see, is very less compared to this. Whereas conventional culture, at least you need at least 72 hours, whereas here within half an hour or 1 hour you can get. So what is PCR? PCR, in simple words, it lets you pick the piece of DNA you are interested in, and you can study as much as you want. It is a chemical process wherein you amplify the target nucleic acid, and then you try to do it as much as copies as possible. Something like a Xerox machine, where you take more number of copies, you take the copies and try to study. And as I told initially, one target. Now also, if you want one specific organism, you have one target PCR, 2 target flu and other things. The multiplex, wherein our respiratory, whatever the common respiratory organisms, you can try to look at. So there are various methods. So having said that, let us go to some case scenarios where you can know. So the first case is 14-year-old boy with high fever, headache, vomiting, altered sensorium, came with breathlessness. He was intubated and ventilated. CT was normal, treated with multiple antibiotics, metronidazole, meropenem, ceftriaxone, etc. Low blood pressure was there. Referred as a case of encephalitis and ARDS. The initial working diagnosis was severe pneumonia with the ARDS and encephalitis, and they continued the initial antibiotics and pending investigations. So this is the X-ray which you can see, looks like more of a ARDS, and these are the few investigations. The CSF showed more of lymphocytes and glucose of 75. And we thought it is a viral meningoencephalitis or a partially treated bacterial meningitis. So with this scenario, if this case comes to you, sir, how will you proceed? because we need a etiological diagnosis. Now it is the era of microbiological diagnosis, whether it is PCR or culture. So how will you do? Because multiple antibiotics have been given and you are not able to look at the, isolate the organism. Dr. Reddy, how you can...
A very good morning, sir. At the outset, I thank AOP and Dwivedi sir for giving us the opportunity to be a panelist in this under the guidance of ID legendary figure, sir, Bhaskar Shenoy, sir. Thank you very much. So the first case, as we all know, 14-year-old, we have typical CNS symptoms. So we have to, various differential diagnosis comes. So basic investigations have been done, and even dengue is negative, malaria is negative, falciparum, CNS manifestations, renal and liver function tests are normal, and X-ray is showing ARDS picture, and CSF also pointing out to more of viral meningoencephalitis. Or since the child is very sick and referred the case, the child might have received the antibiotics outside, and it can still be partially treated bacterial meningitis. In this scenario, we have to prove the bug. So otherwise, if we diagnose it is a bacterial meningitis, depending on the organism, we have to continue for 7 days, 10 days, 14 days. The antibiotics, the higher antibiotics like ceftriaxone and vancomycin, and we have to delete or rule out the viral meningitis. This is the scenario where we can really take the help of PCR, that's molecular diagnostics. So the PCR of CSF culture is, we have low yield, even the blood cultures will not give that this thing, but high specificity and sensitivity comes when you send the CSF sample for PCR analysis.
Yeah, thank you, Dr. Obel. You have given the answer. So here the role of molecular diagnosis comes. We sent a CSF for meningoencephalitis panel, and to our utter surprise, it was Streptococcus pneumoniae. Though the CSF culture didn't grow, of course, we expected that because of the lot of antibodies. So it is ultimately a pneumococcal meningitis with the ARDS and septic shock. Antibiotics were de-escalated. Vancomycin and ceftriaxone was continued, extubated, and was discharged well. So, sir, can you tell me brief about that panel, meningoencephalitis panel?
Yes,
do you send very frequently or in such cases?
Sir, in such cases, when there is a dilemma and when there are some even outbreaks, other things to limit the spread, to diagnose the etiological agent. So we do send ME panel, meningoencephalitis panel, biofilm array. So it covers various bacteria, virus, as well as some fungus also.
What is the role of PCR in general? Where it helps? What are the other uses of PCR?
Sir, PCR definitely it helps in identifying the infectious agent. So we have so many overlapping of the signs and symptoms of many diseases, and it's very useful in identifying the genes of the antibiotics, mechanism of resistance, and some cases for the monitoring and the prognosis of the disease and the estimation of the viral loads like CMV and HIV, for infection control, for detection of MRSA, and for outbreak investigation to prevent the, to identify the bug as well as to limit the spread of the bug in the community. And for knowing the various variants, now we have seen the various usefulness in COVID also and other variants.
Advantages?
Various advantages, as sir said, it is very fast within now the latest advancement of technology, real-time PCRs, multiplex PCR, you can just within 1 hour you can get the report, and a shorter time to optimal therapy, and it improves the treatment decisions. We can stop unnecessary using of the antibiotics, as well as we can take the decisions to continue the antibiotics or to escalate the antibiotics, because as we know in severe septicemia and bacteremia, every hour delay will cause the increase in the mortality by 7.6 to 10%, and it really helps in support the antimicrobial stewardship and unnecessary testing. And finally, we may think that PCR is very costly, but in spite of doing all the battery of investigations, finally, doing the PCR in wanted cases, we really prove cost effective And that's a very, very real advantages of
Yeah,
PCR
thank
in
you,
the
sir.
modern
You
era.
have given the full details about that. It is not only for the diagnosis. There are much more other advantages, including the genes responsible for the mechanism of resistance also can be detected. So thank you, sir. The message from me is that when you are not able to identify an organism, send the PCR, wherein you are able to identify the organism and you are able to de-escalate the antibody. That is one of the other most important advantage of this particular technology. So let us go to second case. Child two and
So the cost is an issue.
Sir.
The government setup like
Yes.
mine.
Absolutely. That's what we told. Cost is an issue, but wherever now most of the patients who are coming to private care, they have insurance. So that is not
We
a.
have limited panels available over here, not validated though. But they include, they're just 3 or 4,000 what they cost. Though not validated, but they do include the common organisms causing pyogenic. The advantage would be, we can decide the number of days of giving antibiotics if the patient is not affording for that
Yeah,
16,000.
especially if the clinical signs or the syndrome you suspect. So you can narrow down the things. Yes. The second case, 2.5 years with the fever, cough, fast breathing, had respiratory distress. You can see saturation was 88 and admitted in a outside hospital where the nasopharyngeal swab was sent for the PCR. They detected human metapneumovirus. The child worsened, so it was referred to our hospital with the ceftriaxone, vanco and linezolid. He was ventilated. So they thought it is due to metapneumovirus and then they sent to our hospital. So child didn't improve, child worsened. Sir, in this case, in your hospital, this child comes, how will you proceed? Do you want to do any other further investigations or you are happy with the metapneumovirus that you got some eureka, I got some virus?
These PCR panels, upper respiratory panels, do pick up the nosocomial infection, the common cells also. But human metapneumovirus is one. There are 3 or 4 which if picked up, they are usually pathogenic. Adeno, your human metapneumo influenza, if they are picked up, they are usually pathogenic. So I'm still sticking to the diagnosis of human metapneumo. The only thing is the patient is deteriorating clinically, right? And it's a PICU patient. And in a PICU patient, 1/3 of the patients might have mixed infections, mixed bacterial infections. The patient not improving, general condition not improving. I still believe it is human metapneumo, but it could be a mixed infection. I'd go for lower respiratory panel because the patient is intubated. Why not take a tracheal aspirate and get an lower respiratory
Absolutely,
panel?
you have given the right answer. Sir, this child was investigated. All the routine investigations doesn't show much. This is the X-ray of the child and he was ventilated, and during the ventilation, we sent the tracheal aspirate for the thing. We didn't believe that only because it was a nasopharyngeal aspirate. We didn't give much importance to that. We went ahead with the tracheal aspirate, and tracheal aspirate showed Streptococcus pneumoniae, the first one upper, in addition to metapneumovirus. So metapneumovirus was there, but the tracheal aspirate showed Streptococcus pneumoniae. Now you have the answer. Antibiotic were de-escalated, and then we continued for the full course, and child is now it's there in the hospital now, and it is now shifted to the ward with a stable. Of course, it is a politician, minister's grandchild, so everyone was on the tip of the toe. So, sir, as you told, the upper respiratory and lower respiratory you mentioned. So, what are the differences when you choose these things, and what are the advantages over the other?
The specimens, upper respiratory would give you, we will take from the throat swab or a nasopharyngeal swab. Lower respiratory would be either a bronchoalveolar lavage or a sputum or a tracheal aspirate.
So the multiplex of these things, PCR, they can, depending on the panel, you can detect multiple viruses, and one which is commonly done by the film array contains all these around 20 respiratory pathogens also can be done, but only thing is the cost is a limiting factor. These all viruses can be seen. The organisms like pertussis organisms, mycoplasma, chlamydia, which cannot be detected by a typical, I mean, the conventional method can be detected. About 20 organisms can be detected. Sir, can you tell what are the various types of PCRs that is available? Because just for the audience interest.
There are conventional PCR, there are real-time PCR, which basically monitors the DNA amplification in real time and it gives you faster results. Like we send it for TB, like Gene Expert. Then there are RT-PCR for the from RNA to DNA by reverse transcriptase enzyme converts from RNA to DNA for especially for RNA viruses. And there are multiplex PCR. We are talking about biofire from the ESF or from the other body fluids like bronchoalveolar lavage.
Yes, sir. There are many more terminologies which I don't want to confuse, but these are the basic 3-4 terminologies. If you can remember, that is more enough, more than enough. But these have their own limitations because they can detect only the target which you are put it. The predefined targets which are there, only that it can. Unlike culture, even if it is a rare organism, you can detect. But here, whatever is a predefined or preloaded, that only organisms can be detected. Resistant genes we told, and it doesn't give antibiograms like cultures. And some pathogens are colonizer. It doesn't recognize between a colonizer and a pathogen. For example, strep pneumonia in HIV can be in the upper respiratory tract. And it is a nucleic acid, so it doesn't differentiate between a dead and a living organism. And it is not useful for the detection of end of the treatment also. So these are the panels which you can see. The clinical performance, if you look at the various organisms, they are around, the sensitivity is around 98 and the specificity around 99% for all the organisms which you can see. And this is a paper wherein they compared the film array respiratory panel compared to the conventional methods, wherein the standard and the film array on the other side, that improved the detection by 15%, whereas if it is a nasopharyngeal aspirate, it improved the detection by 30%. So detection rate is more important. And if it is a more lower respiratory tract infection like BAL, the specificity and sensitivity increases. So let us go to the third case. 4-month-old with the respiratory distress, hepatosplenomegaly, mother had TB, and we suspected miliary tuberculosis. Of course, as the standard protocol, we sent CB-NAT and AFP for staining. This is the picture, and this is the end of the treatment, the miliary tuberculosis. And we sent a Gene Expert wherein the ball was taken and it showed even the AFP was positive and CB-NAT was positive. And LPA was also sent, and LPA Gene Expert showed rifampicin resistance, of course. And this showed rifampicin sensitive, the LPA showed. So now I want to ask you, sir, what are the, Devesh, what are the advantages and in TB diagnosis, role of PCR?
Yes, sir. So yesterday, sir has covered part regarding
Now, briefly you tell, yeah.
So basically, CBNet, it is going to give you result very fast, sir. It is automated. You have to just load and within 45 or 2 hours, you'll get the result. In LPA, you have to do many things manually. So it will take longer time. It is little bit expensive, so not everywhere available. The advantage of LPA over CBNet is that in CBNet, we can only see for rifampicin resistance. But in case of LPA, along with rifampicin, we can also look for isoniazid and second line antibiotic as well, sir. Now, regarding the discrepancy in CBNet report and LPA, so sir, when there is very low viral load, there are chances that CBNet can have false positive for rifampicin resistant genes.
I'll come to that. So he has clearly told what are the advantages of that. But now I am surprised. Though they say PCR is a final or the best method. Here we have used PCR. In CBNAT, it has come as rifampicin resistance, and LPA, it is rifampicin sensitive. How will you explain that?
So it is observed that when there is very low viral bacterial load, there are chances that CBNAT can pick up false resistant in rifampicin resistant. So even in our NTEP guideline also they have mentioned, and there are a number of publications which suggest the same thing, that if you are finding rifampicin resistant in CBNAT with very low bacterial load, you should also correlate with clinically. If there is no signs, there is no exposure of MDR TB, child is responding well, and you are not suspecting that this child is having rifampicin resistant, then you'll always ask for LPA and MGIT, which is a liquid media. And what is the final report from LPA and MGI you should consider, rather than just relying on.
Yeah, absolutely. So the other advantage is that it helps to differentiate between CAT, G and INHA mutations for INH resistance. Wherein if you are able to detect that, if it is CAT G, you cannot increase the INH dose, which will not be helpful. Whereas if it is INH A mutation, higher dose of INH will definitely help it. So that is the advantage of rationalizing or streamlining this antibody. So the PCR role comes here, and we are used to only the rifampicin resistance, but now with the LPA you can look at more resistance organ, but there is no genotypic test at present for ethambutol and pyrazinamide. It is for other things which you have already told. So it is, one is, the reason is the low bacterial load in the sample. There are some silent mutations, that's what they describe. So current guidelines, if you are able to see the rifampicin resistance, which is indeterminate by CBNAT, we should always go for LPA. That is the message. These are the differences
So why not
between.
repeat a CBNet?
Pardon, sir?
Why not repeat a CBNet? Intermediate.
Yeah, repeating CBNAT also has been advocated by some agencies, but LPA is the best thing because you will look at more number of drugs for which resistance can be found out. So these are the few papers that Devesh was mentioning, which has given clearly about these things. Let us go to the fourth case, sir. It is a PICU case, so you are the best person to take it. Fever 4 days, sick child on norepinephrine ventilator, culture grew gram-negative bacteria, E. coli, which is carbapenem resistance, that is CRA. So what will you do, sir, in such cases?
If we have availability of biofire respiratory panel with resistance pattern of the genes, then we can go for that. That will give you whether the CRE carbapenem resistant is because of carbapenem or other mechanisms. And if it is if it shows if it is there are several different classes of carbapenems like A, B, C, and D. And then if it is in India, it's mostly OXA48 and NDM MBL resistance, metal-beta-lactamase. So if it is OXA48, we can give a newer BLI, beta-lactam BLI like ceftazidime avibactam. And if it is new metallose enzyme, then it's we can add estrionam. Avibactam. But if we don't have any of this availability of this enzyme resistance pattern, then we can just go empirically with polymyxin B, polymyxin which and if it is a urosepsis like UTI related sepsis, then polystyrene is the drug of choice. And if we are suspecting abdominal infections or skin soft tissue infection, we can add tigecycline. And sometimes prolonged meropenem infusion in addition to this polymyxin also helpful.
You have something to say, sir?
Tigecycline, usually the setup is usually a VAP is what we face with.
No, here what I'm trying to tell you is
may not work in
see,
the
in
lungs.
such cases, people use empirically. But if you have a molecular diagnosis, you can target. That was the message we wanted to give. Now, can we diagnose in our practice? Yes, there are various methods of diagnosis of these resistance patterns. One which we do is expert Carba R, because it depends on it is based on the Amber classification of CRE. I will not go into the details. It is like this. And based on that, this is the paper from Journal of Pediatric Infectious Disease Society, and it clearly gives which antibiotics to be used when you have that particular type of mutation to that particular bacteria. So this particular test can be actually, we do routinely in our hospital. And of course, as you told, it may not be available in many of the hospitals. And it detects, it is performed on Enterobacteriaceae, Pseudomonas and Acinetobacter. It tries to define the type of carbapinamase because the drug changes. But the thing is that it detects only 5 genes as of now. Probably over a period of time we will be able to detect. There are hundreds of genes, but defective genes, but only 5, that is KPC, NDM, VIM, IMP and OXA48 can. And it gives result within faster result. Of course, the cost in our hospital is around 2,000 or 2,500, not a very costly affair compared to the results that we give. And here, Devesh, this child got Carba R report now, NDM is detected. How will you proceed?
Yes, sir. Sir, I'll just take a few brief seconds. First of all, to treat Carbar Enterobacteriaceae, if you are knowing few basic, it is very easy to handle this bug. To know the resistant mechanism. So we all know about penicillinase and ESBLI. So they are basically enzyme present in the cell. So similarly, I am talking about Enterobacteriaceae, not other gram-negative organism. So what happens, penicillinase is also an enzyme which is present in the cells. So whenever there is penicillin antibiotic is available, this enzyme going to destroy it and it is not giving opportunity to neutralize the bacteria. So now to do this Carba test is a classical example of molecular study to identify the drug sensitivity. So what we are going to do, we are going to look for the most important gene. As I told, there are more than 100 of genes responsible for carbapenemase production. But these are the 5 most common enzyme genes which produce carbapenemase enzyme in more than 1995. So
what drug you will give now for this
yes,
NDM detected child?
Yes, sir. So this NDM is the most common organism in India and it is a metallobeta-lactamase. So we have only few options available in India, only ceftazidime, avibactam, along with estrionam we can give. Both you have to.
So if you look at the chart, see NDM, the best drug would be cefiderocol, but which is not available in India. So for that we give ceftazidime, avibactam and estrionam. That combination works good.
Sir.
Yes.
And merovirobactam in few centers are available.
So this is the other choice of antibiotics how can. And we had the opportunity of publishing this paper with the Devesh and the prevalence of carbapenem resistance in our hospital, and which is accepted by European Medical Journal. Devesh is a part of this study. And next case, we will go because time is very short. They are very stingy about the times. So next case, 3-year child, fever of 3 weeks, headache, treated with the multiple antibiotics. And this child provisional diagnosis was Coiri Adam, Coiri TBM. So what are the management plans, sir?
A prolonged acute CNS infection, first would be an MRI. MRI brain with contrast.
So this MRI brain showed a large abscess in the temporal area with midline shift, started on ceftriaxone, metronidazole, vancomycin. Cultures were stable, normal, sterile. And after 7 days, again he developed this thing. And MRI brain was taken, and you can see the large abscesses here. What are we dealing? How can you get into the etiological diagnosis? That is my question now. Now I can't beat around the bush because it's a very serious case. So any newer technologies wherein you can take some help to improve the outcome of the patient? Anybody?
Pus culture is negative, and the routine PCR panels have a very limited area of the organisms that we target. So I need something that gives me pan-bacterial etiology, right? And the newer test, they call it is the 16S RNA sequencing that can be done in a negative pus culture, or a culture which does not give you a phenotypic classification, wherein we can use a 16S RNA DNA sequencing is the newer technology.
Can you briefly, just 2 sentences, what is it? Because the audience, though it is not available freely now, but it likely to come in some years. So let us.
16S RNA gene is a part of the bacterial gene. Classical characteristic that is useful for us is this gene is present in all species of bacteria, number 1. Number 2, it is very specific, it is species specific, this gene, and the size of the gene is large enough for the study. That's why we can use the 16S RNA gene to pick up, pinpoint the etiology of the bacteria. What we do is extract the bacteria, extract the gene, amplify the 16S RNA portion, sequence it, and then compare it with the gene bank. We'll get the etiology.
Absolutely. So this particular child, we could detect Streptococcus intermedius, and then it was treated with the ceftriaxone, and he improved. I'm little hurrying because of the time. So that is one sir. Yeah. Yeah, that is one thing in blood culture positive cases. Or culture
Or
positive
undefined
cases.
blood culture, where the blood culture is not phenotypically able to detect the organism. Yeah, when the blood culture is inconclusive rather than negative.
And one more thing, in 16R RNA, there are also chances that it get contaminated from the environment. So it is always better if you are doing 16R RNA to do from sterile fluid at CSF, because if you done from some
Okay.
there are chances of false.
Yeah, thank you. Last case, 1.5-year-old, fever, left focal convulsion, altered sensorium, and no meningeal signs, CSF normal. MRI showed hyperdensities in the right temporal, parietal, and bilateral frontal and occipital lobes with the bilateral temporal hemorrhage. EEG is PLEDS. So, sir, how will you manage?
So this is a basically acute viral encephalitis. MRI picture and EEG is consistent with HSV encephalitis. PLEDs are quite specific, not always, but usually in clinical picture, I think it reflects the HSV encephalitis.
Yeah, what are the typical CSF findings that you see in HSV?
Usually you have a hemorrhagic encephalitis. So there are RBCs in the CSF plus leukocytosis with lymphocytic predominance, and the sugar is usually normal. Proteins may be mildly elevated but not very high.
And sometimes it may be initially normal also.
Normal, yes.
So confirmation is by Dr. Obel. How will you confirm this? Now you have suspected because PLEDS is there. The MRI shows
Yes.
CSF is not very classical.
Yes. So this is the situation again. Our molecular diagnostics really help us. If you send a CSF panel, MU panel, we will find the organisms, and we can be definite in finding out the diagnosis, where we can de-escalate the antibiotics, or we can choose right antiviral drugs in order to cure this thing.
So here PCR was positive HSV1 treated with the acyclovir, and the thing is that it is a 98% sensitive and a 94% specific, but false negatives can occur, especially if there is a low viral load, or if it is done in the early part, that is day 1, day 2. Sometimes it can be negative. So in that case, if you have a strong suspicion of HSV encephalitis, especially a clinical picture, especially a EEG picture of PLEDs, especially a MRI picture showing what we have showed typically, then if you have a strong clinical suspicion, you go for repeat CSF HSV. So that will definitely give, and of course we have spoken about the advantages. Limitations is that CSF, it doesn't, CSF PCR, I'm not talking about HSV PCR. In general, it doesn't detect JE, rickettsia, dengue, TB, and some of the other viruses. And we have to, we can keep it under refrigeration for 7 days, up to 7 days, and we should not centrifuge. That one thing we have to remember. And this is the panel which you generally see. The volume required is very less. And these are the few guidelines, European Society of Clinical Microbiology and ID guidelines. Now the question comes, we talk about syndromic diagnosis. What do you mean by syndromic diagnosis? Anybody can answer. No.
CS together, what we used to do is just give a syndromic diagnosis. Say the patient is having right upper zone pneumonia, but the etiological diagnosis, pneumococcal pneumonia, or this, that we were missing till now. This PCR and these molecular diagnostic tests. Now we move from a probable diagnosis to a pinpoint diagnosis.
Yeah, that means there are multiple symptoms can be mimicking, caused by one virus, or multiple viruses or bacteria or organisms can cause a single kind of picture. So that is very difficult to microbiology diagnose. So that time we do syndromic diagnosis. This is how the syndromic approach goes. I will give some examples of syndromic diagnosis. For example, these are the 4 X-rays where they all have alveolar infiltrates. Maybe the age is different, but the clean X-ray pictures are same. But when you do the etiological diagnosis, one is rhinovirus, the other one is meta, other one is EV, other one is adeno. So various organisms can cause similar picture. So you are trying to differentiate. So we have come to the answer.
Last 2-3 minutes.
No, I am in the end. I am in the conclusion.
Okay.
So as we discussed, the molecular platforms are available for rapid diagnosis. It definitely has a curve on antibiotic misuse. It limits the antiviral use also, and it limits the unnecessary investigations in other setups, and it helps in the management of high risk patients and prevent the outbreak, reduces the hospital stay, early diagnosis, mortality and morbidity can be less, and they are a real boon. And the thing is that we should know the limitations. This is an interesting article that I could read. Is it time to substitute culture with the molecular diagnosis for infectious disease? Not yet. Culture is culture. It will be there. It has to be there. Along with that, whenever there are culture negative things, we may have to substitute. So now the points that we learned from each of the cases is that when you do the PCR, it helped in the etiological diagnosis. It helped us to know what is the right sample that has to be taken, whether it is upper or lower. It helped us to know the antibiotic resistance pattern so that we could give a targeted therapy and the patient who was very sick and improved. So these are the messages that we were trying to give from this panel. Thank you, panelists, for a wonderful job. And my own student, Devesh, is there, who did fellowship under me, and he's in Ahmedabad. So it is still a good opportunity for me to encourage the young IDs to come up. So if you ask me right questions, I have some good answers. Thank you so much.
These PCR panels and panel discussions, whether you like them or not, they are the flavor of the day.
Thank you very much, sir, for simplifying this complex molecular testing.
Sir has one.
Yeah.
Mike. what we are doing in practice, and empyema fluid sending in the, as ball sample or as pneumonia panel. And we are growing, I'm always having some bug, and that's interesting. And out of 3 cases, then I had a talk with the biomedic. I discussed with several people published all over the world where people have done this jugaad. So we are not the only one.
Yes, sir.
And
That-
okay, because many a times you see you are giving high-end antibiotics to a sick patient, and you feel how long can I give it? And in that situation, do this jugaad, and you find a bug and streptococcus pneumonitis. You are very sure that you can get away only with one antibiotic. And we did in 2 patients, and successful that.
Yes, sir.
And biomedics people told me said they are also doing a study now. After realizing this, the people have done on this.
The similar thing we have done in our center also. The few things, sir, as sir also told that biofire costs somewhere 12 to 15,000 and fewer local available which are costing 3 to 4,000. The only problem, only multiplex PCR which is FDA approved is biofire. So if you are practicing evidence based and if you want to, biofire. But the another thing that biofire, they are asking to do particular sample only because they have that data only. If you request microbiologist and they are ready to do, you can get it. But the thing is, it is not approved for.
I
That is
think
why
we have to
are
write
can't say
ball
it.
and send.
But we are doing and it is come out to be positive.
That's the reason I told you, not validated.
Yeah,
But,
exactly, sir.
interestingly,
I think it should be validated, should be validated.
other thing is you said you second Tango plus,
Hmm.
they are antagonists.
No, it was given, then we can, when it came to us, it was. Thank
I
you so
thank-
much.
Thank you, sir. Thank you all
Thank
panelists
Dr.
for.
Bhaskar